We have a clinical vignette, 73 years old male, with 2-year history worsening pain in both knees. Worse at the end of the day after walking or climbing stairs. Okay, improve with rest, so rest and no pain, but pain get worse when walking or climbing the stairs. Okay, he knows the stiffness less than 10 to 15 minutes upon walking in the morning. So we have a 73 years old, 2-year history of pain in both knees. So knee stiffness less than 10 to 15 minutes when he walking in the morning. Walking in cause pain, but for rest and no pain. Okay, walking or climbing get pain in the knees. When rest and no pain. Okay. Now physical examination, bony enlargement and joint crepitus on flexion and extension of both knees. Flexion and extension have a bony enlargement and joint crepitus on flexion and extension of both knees. So joints are non-tender to light palpation without erythema, warmth, or significant inflammatory soft tissue effusion. Okay, now I have a bony enlargement and joints crepitus on flexion and extension of both knees. Non-tender. Okay, radiography, asymmetric joint space narrowing and subchondral sclerosis. So then what's the most appropriate diagnosis? Chronic gouty arthritis. I don't think this is a gout. Psoriatic arthritis, rheumatoid arthritis, or osteoarthritis. Remember, radio say asymmetric joint space narrowing. The joint space narrowing subchondral sclerosis. So this have to be this osteoarthritis. I think. So the correct answer is osteoarthritis, right? So that makes sense. So when used and painful, but when rest and no pain. Bony enlargement and joint crepitus, flexion and extension of both knees. So correct selection also arthritis, okay? Now detailed clinical explanation. Classic osteoarthritis features degenerative articular cartilage breakdown characterized by activity-related joint pain, brief morning stiffness, less than 30 minutes, bony enlargement, osteophytes. So that's a bony enlargement stand for osteophytes, crepitus, and absence of stomach or mark the local inflammatory size. Okay, that's a classic osteoarthritis, which is degenerative articular cartilage breakdown characterized by activity-related joint pain, brief morning stiffness, less than 30 minutes, bony enlargement, which also finds crepitus and absence of systemic or marked local inflammatory size. So radiographic findings, asymmetric joint space narrowing, subchondral sclerosis, subchondrosis, and osteophyte formation. So radiographic findings, asymmetric joint space narrowing, subchondral sclerosis, subchondrosis, and osteophyte formation. Now, detailed disease treatments and management the osteoarthritis about the non-pharmacological interventions, which is core therapy. Huh? So this is a core therapy, which is non-pharmacological interventions. Number one, this is a weight management, weight loss in overweight patients significantly reduce mechanical load on weight-bearing joints. Control weight, that's very important. So number two, physical therapy and exercise. Low impact aerobic exercises, swimming, cycling, and quadriceps muscle strengthening. So assistive devices, use of walking canes, held in the contralateral hand, knee braces. I think better let the patient, which is old enough, walk with the walker safer than walking canes. Walker have a four thing, have a two slides and two wheels in there. So walking cane is just a one thing that how sometimes falling down. So assistive devices use a walking canes held in the contralateral hand, so knee braces or shock absorbing footwear inserts. Now, pharmacological step ladder management, topical and sets. First line, like topical diclofenac gel 1% preferred in older adults due to minimal systemic absorption. So diclofenac gel 1% preferred in older adults due to minimal systemic absorption. Number two, oral analgesics, oral acetaminophen, maximum 3 grams per day, or short course oral NSAIDs with a PPI gastroprotection if topical therapy is inadequate. Intra-articular injections, intra-articular corticosteroid injections for acute pain flares, intra-articular hyaluronic acid as alternative option. Number two, pharmacological step ladders management, topical NSAIDs, first line oral analgesics, which is acetaminophen, intra-articular injection, corticosteroid injection for acute pain flare, intra-articular hyaluronic acid as alternative option. Okay, now surgical management, total knee arthroplasty, TKA, total knee arthroplasty, indicated for end-stage refractory osteoarthritis with severe pain and functional disability failing conservative management. Okay, why other options wrong? Rheumatoid arthritis, no, because the systemic inflammatory autoimmune disease with prominent morning stiffness lasting more than 60 minutes. Huh? But in this case, which is lasts around 10-15 minutes, then no more pain. But for the morning stiffness, which is in the RA, rheumatoid arthritis, which is more than 60 minutes, more than hours. Okay, that's number one. Number two, which is this symmetric involvement of small hand food choice, like a MCP, PIP, warmth, bulky, swelling, elevated ESR, CRP, you know, and positive with RF or anti-CCP. For psoriatic arthritis, which is seronegative spondyloarthropathy associated with skin psoriasis, nail pitting, dactylitis, sausage digit, and DIP joint involvement. About chronic gouty arthritis, which is deposition of gout, you have to have a uric acid, which is monosodium urate crystals, causing recurrent severe inflammatory mono or oligoarthritis with soft tissue tophi and erosions, punch out lesions on radiography. Okay, now summarize. This case is 73 years old man, 2 years history, right? Which is have a morning stiffness less than 30 minutes. Okay, which around 10-15 minutes in the morning, and when use the joints and get a pain. Okay, like a walking or climbing on the stairs, but when rest, no more pain. Okay, for physical examination, they'll have a we feel like a bony enlargement and joint crepitus. Okay, other than that, nothing wrong. Bony enlargement, we see bony. Okay, and also radiography, the important, we see the asymmetric joint space. Okay, asymmetric joint space narrowing and subchondral sclerosis. So then for this condition like that, diagnosis, which is in the old patient, and with a condition like that, and we know this osteoarthritis. Okay, the reason why this osteoarthritis, because this is a very classical osteoarthritis features, which is this a degenerative articular cartilage, right? Breakdown characterized by activity related joint pain, some brief morning stiffness, less than 30 minutes, bony enlargement, have a crepitus, and absence of systemic or marked local inflammatory sites. Okay. And next one, which is in radiographic findings, we see asymmetric joint space narrowing. So that's, and then subchondral sclerosis, subchondral cyst, or osteophyte formation. Okay. So when we diagnose the osteoarthritis in the older patient, what should we do? Okay. So treatment, which is life modification, which is non-pharmacotherapy, very important, which is no medication, they call no non-pharmacological interventions. This is a core therapy, right? So what we do which is weight management, important. When we reduce weight, that's a very significant to reduce mechanical load on weight-bearing choice. Number two, which is physical therapy and exercise. So low impact aerobic exercise like a swimming or cycling. Why they don't recommend other thing, huh? They recommend swimming, cycling. So they recommend use a low impact aerobic exercise like a swimming, cycling, and quadriceps muscle strengthening. Uh-huh. Now, assistive devices which you use a walker can, I think better use a walker which you have a two slides and then two wheels that and knee braces or shock absorbing, you know, kind of like that. Hi Darius. Thank you. You are watching from Israel. Uh, Thank you very much. Assistive devices use walking canes. Okay, held in the contralateral hands. Oh, okay. I think use a walker safer because they have enough space for we use two hands to hold and safer, especially in the older patient like this. They support to walk and prevent the falling down. Important, prevent the broken the neck of the femoral bone. Anyways, or use a knee braces or shock absorbing footwear insert. Beside that, if we use a pharmacological or which is medication, what we use a pain relief mainly, Tylenol, acetaminophen. This oral or use a topical type which is use a diclofenac gel 1%. The reason why this one because in older adults due to this minimal systemic absorption. This a minimal systemic absorption. Now, intra-articular injections, intra-articular corticosteroids injections for acute pain flares. So, intra-articular, so hyaluronic acid as alternative option. Otherwise, then use surgical management, which is total knee arthroplasty. So this is end-stage refractory osteoarthritis with severe pain and functional disability. So then we have to use that. Other option draw, for example, like RA arthritis, rheumatoid arthritis. That's scenario different. If rheumatoid arthritis, then morning stiffness have to last in more than 60 minutes. Okay, and have increase ESR or CRP, and also have a positive with the RF, which is rheumatoid factor, anti-CCP, something like that. And they are symmetric. It's not asymmetric. This is symmetric involvement in small hand foot choice like MCP or PIP and boggy swelling, something like that. Feel warm, inflammatory because rheumatoid arthritis. That's an inflammatory autoimmune disease. You know what I mean? Now, about the chronic gouty arthritis, gouty, then we have a tophi, which is like a soft tissue tophi erosion. We see this punch out lesion on radiography, and this one is just recurrent, due to the deposit of the uric acid, monosodium urate crystal, and the one choice or multiple choice, like a mono or oligoarthritis. About psoriatic arthritis, this one they call they have a pattern. They call this a sausage digit. That's psoriatic, which is sausage digit. Huh? Remember that when we see sausage digit, and then we know that. Okay, that's about it. Thank you, Darius. Have a nice day.